Our next session is the expanding burden of long COVID implications for population health. Two of the panelists will be online, two will be here, and I'm going to let the moderator, Dr. Gary Groot, otherwise known as Groot, to start by introducing himself. Thank you.
Congratulations for those of you who have made it this far. I am Groot, and I'm a co-lead of Pillar 4. Ellen Rafferty, my other co-lead, is not here with us today, but she has been a stalwart alongside me. I'll be monitoring this final session of 4 absolutely amazing speakers this afternoon, and those of you who have decided to stay on and are here with us are in for a treat, believe me. The way we're going to run this, I will ask each of our 4 speakers to just introduce themselves. That's Nicole, and then Gosia, and then David and Matthew will be virtual. And then after that, there will be a Q&A session. So let's get going. Nicole.
Good afternoon, everyone. My name is Nicole Shaver, and I'm a Senior Clinical Research Associate based at the Knowledge Synthesis and Application Unit at the University of Ottawa. Before I begin my session today, I'd just like to briefly acknowledge the large team whose collaboration and support has made this work possible, and also acknowledge the land on which we carry out our work in Ottawa. So by the end of today's session, I'd like to discuss the following 3 questions. The first is, what are the effects of long COVID on workers? Followed by how these effects translate to the Canadian healthcare workforce. And then dive a little bit deeper into our current understanding of the barriers and facilitators for the return to work process. So as we've heard over the past few days, we know that long COVID remains a significant global burden. And long COVID can have a number of different impacts on individuals who are afflicted with it, including severe impacts on overall quality of life and daily functioning. And this includes occupational impacts. And workers can suffer from a variety of different outcomes related to a need for extended sick leave, absenteeism, and delays in return to work. And in turn, these can have an effect on the overall workforce. Additionally, what we saw during the pandemic is that additional staff-related shortages and disruption of services and a heightened demand in other workplaces exacerbated some of these effects in the overall workforce. And while we had a good understanding that some of these effects were emerging when we set out on this research, we didn't have a clear picture of what this looked like in the Canadian workforce. Additionally, we were interested in these effects in workplaces where there was a higher degree of frontline facing workers who therefore may have had a higher risk of developing COVID, and then in turn, a higher rates of long COVID. We were particularly interested in the healthcare workforce. So we set out to do some research on this and obtained a CIHR Catalyst grant to examine first, what are the effects of long COVID on workers, and to look at the global burden through a living systematic review to consolidate the current state of evidence and critically evaluate what we were seeing. And then we also wanted to see how these effects translated to the Canadian healthcare workforce. And there weren't as many studies in this area when we set out on this topic, so we decided to include a modeling component to the project. So briefly, we decided to carry out searches starting in January 2020, and we completed them up until May 2025. And we had a number of different criteria that were defined a priori, but basically we were looking at those who were the working age population, and we were primarily interested in comparative research. So research that was examining individuals who were affected with long COVID compared to those who were exposed to COVID-19 but did not develop long COVID following acute infection. And we looked at a number of different work-related factors, primarily through observational studies. Next, for the second component, we partnered with our colleagues at the Public Health Agency of Canada and collaborated in building an agent-based microsimulation model. So this model was built to look at the long COVID burden in healthcare workers in Canada, and specifically estimate worker retention and productivity at both the first year and the second year post-acute infection. And this was populated with data somewhat from our living systematic review results, but primarily using a representative sample of data from the 2021 Canadian Community Health Survey. So following 3 iterations of our living systematic review, we included a total of 82 studies. The majority were conducted in Europe, and the majority were cross-sectional in design. And we did see a mixture in quality when evaluated across studies, with the majority being at moderate risk of bias. Additionally, we saw a really high degree of clinical heterogeneity, which meant that we weren't able to pool our results via meta-analysis, and instead described what we were seeing via ranges and medians across studies. Contributing to this heterogeneity, we saw a really high degree of variation in the measurement and definitions of long COVID, especially in research that was being conducted at the beginning of the pandemic as these concepts were still emerging. We also noted a really high degree of variability in work-related outcomes, and noted that these often relied on self-reported measures as well as non-validated measures, which made it difficult to assess what was really going on in some of these studies. To highlight some of our key findings, we did see that a high proportion of participants did return to work within the first 6 months, with a median of 84% observed across studies. But we did note that accommodations or modifications were very commonly reported amongst the studies that did have these proportions of workers returning to work. For our comparative findings, we did see that those with long COVID generally fared worse than those without long COVID following acute infection. And this was true across a number of different outcomes that we looked at, including delays in return to work, lower workability, lower functional status, decreased productivity, and higher rates of absenteeism. But we did see a high degree of quality across these studies, which lowered our certainty in some of these estimates. Additionally, we saw that trends in work-related outcomes were similar both in the general population and in studies that looked at particular subsets of populations only involving healthcare workers. When these results were applied to our agent-based modeling results, we did see that there was an increased number of workdays lost through the model. And this was increased in healthcare workers with long COVID compared to those without long COVID. At the 1-year mark, there was an excess of 75 days lost, and there was 96 cumulative days at the 2nd-year mark post-acute infection. So to sum up, our results did suggest that workers with long COVID faced an increased occupational related to long COVID compared to workers without, but the quantitative data was very heterogeneous, and we can't be sure of the exact magnitude of impact for each of these outcomes. But we did note that there was a significant burden, and we are seeing these trends emerge again and again across these outcomes. Again, when these were input into our model, we do see a considerable burden of long COVID on Canadian healthcare workers. And this is clearly persisting both at the 1st year post-acute infection and into the 2nd year post-acute infection, which may in turn have considerable long-term consequences. So next, we wanted to dig a little bit deeper into our current understanding of barriers and facilitators for the return to work process. And we know that this is a complex process, so we wanted to turn to the qualitative data and look at people with lived experiences. So we decided to conduct a scoping review of the qualitative research using our long COVID web seed funding. And we looked again at the working age population, either working age adults with long COVID or those who are responsible for treating and caring for their patients with long COVID. And again, we included qualitative or mixed method studies that included any barriers or facilitators related to return to work or workability following long COVID infection. And we wanted to take a biopsychosocial lens to this component of the project because we know that the return to work process is quite complex. And beyond the initial symptoms that individuals are experiencing, there may be other factors related to their ability to return to work, including environmental factors or personal factors. So we completed our initial deductive coding using the WHO International Classification Functioning Disability and Health Model, also known as the ICF. for our initial deductive coding, that we were also open to emerging themes that did not fall neatly into this framework. So from this study, we found a total of 29 qualitative or mixed method studies with a total of 1,900 participants across studies. Again, the majority of research was conducted in Europe and included populations, the majority being with long COVID, but we also did see a few papers about the opinions of specialists, so physicians or rehabilitation experts. And while we're still in the process of finalizing our final conceptual framework, I just wanted to highlight a couple of the key findings that we've seen so far emerging from the data. So consistently across studies, of course, an interaction between symptoms and job pressures was noted as a major barrier for participants in their return to work. Both cognitive symptoms such as brain fog and physical symptoms related to fatigue or post-exertional malaise. The cyclical, evolving, and changing nature of symptoms was often seen as a barrier by participants, as it made it very hard to plan the return to work process and often resulted in delays and setbacks when they returned to work too early and experienced a relapse. Among psychological factors, a loss of work-related identity was often cited as something that had a negative effect both on individuals' workability and their mental health. For facilitators, social support was seen as a key facilitator, both for participants by their peers and colleagues within the workplace and for those outside the workplace, such as friends and family. Additionally, a COVID-aware organizational culture was seen as a key facilitator among participants between studies, and having managers and colleagues that understand the burden of COVID and the effects of long COVID and have it seen as a reality. Additionally, a collaborative return to work planning process between both the employee and other stakeholders was seen as a key facilitator. Interestingly, sick leave policies or accommodations could either be seen as barriers or facilitators, depending on how accessible they were as cited by participants and how flexible they were. So to conclude, our findings do suggest that workers with long COVID may experience worse work-related outcomes than those without long COVID. But the emerging data is still quite heterogeneous, and we aren't able to estimate the exact magnitude of some of these impacts. But we do see that they are consistent and that there is a burden. Additionally, we know that long-term COVID may have, long COVID may have long-term consequences for the Canadian healthcare workforce. And this was modeled to be significant at both the first year and second year post-acute infection. Additionally, from our qualitative research, we know that several factors may influence the return to work process, including social support, flexible organizational policies, and accessible accommodations, which may give us some ideas for supportive policies and interventions moving forward. I'd like to thank you for your time.
Good afternoon, everyone. Thank you very much for inviting me to participate. It's my great honor and pleasure to present today. I would like to acknowledge that I live and work on the land where the Bow and Elbow rivers meet, which is a traditional gathering territory, gathering site known as Mohkinstsis to the Blackfoot, Wichispa to the Stoney Nakoda, and Gusitsis to the Tsuut'ina nations. On that land and that place, I strive to learn together, walk together, and grow together in a good way. My name is Gosia Gasperowicz. I'm a developmental biologist with background in biophysics. I'm a member of Canadian Aerosol Transmission Coalition. I am co-founder of Protect Our Province, Alberta. I'm a member of covidisairborne.org and Europe A Patient Association. Since the beginning of the pandemic, I've been analyzing the spread of SARS-CoV-2 virus, the dynamics of its spread, and advocating for better pandemic response policies. I predicted the first 6 waves, sometimes months before they became obviously visible to everyone. I predicted that vaccines only won't stop the pandemic. Also, I warned and explained mathematically why the so-called mild Omicron would kill a lot of people. Unfortunately, all those predictions came true. Today, I would like to share with you my predictions about increasing numbers of people with long COVID due to constant reinfections. And I hope that together we can take steps to prevent this from happening. So long COVID is caused by SARS-CoV-2 infections. Without infections, there is no long COVID. This figure shows, sorry, I have long COVID too, so I have to read. So this graph from COVID-19 Immunity Task Force shows in percentage how many Canadians had anti-N antibodies, so infection-induced antibodies. So basically shows how many people were had been infected over time. And we can see that before 2022, but less than 10% of Canadians had been infected. And in Atlantic Canada, it was less than 3%. And then the mass infection event came in 2022. And then since then, like more than 80% of Canadians got infected at least once, and we are getting reinfected over and over and over again. So a study on Quebec healthcare workers showed that near 90% of people with long COVID in that study had their first infection during Omicron. So that means that vast majority of people who have long COVID have it because of infection of Omicron or subsequent variants. I base my predictions on reports from PHAC and Statistics Canada from 2022 and 2023. Those reports showed that we have there's a high number of people who have long COVID, and this number was increasing. It increased, almost doubled from 2022 to 2023, and now it's, 3.5 million people, in 2023, 3.5 million people had long COVID at some point. Among them, 2 million, so almost 7% of Canadian adults had ongoing long COVID, and among them, almost 500,000 had severe long COVID, severe ongoing long COVID, which means often or always limiting daily activities. So a little bit about cumulative risk concept. Cumulative risk increases with each play. The more you play, the higher the risk. It's like rolling a dice. The more time you roll, the higher the chance that you get 6 at least once. Here we see theoretical cumulative risk curves when the risk per individual infection is 1, 4, 10, or 20%. Results from many studies in many countries show that indeed cumulative risk increases with infection. And they follow perfectly the cumulative risk growth curves. Specifically, in particular, Statistics Canada and PHAC report shows that among people who reported having one COVID infection in Canada, 14.6% had some long COVID symptoms. Among those who reported 2 infections, 25% had long COVID symptoms. And among those who had 3 infections, 38% had long COVID symptoms. So on the basis of those data, those data lay perfectly on cumulative growth curves. On basis of those data, I made long COVID projections for summer 2027. It's based on just few data points. Like every projection, it can change once we have more information and more data. But here I would really like to stress that we need mathematical projections, even if they are imperfect. Without math-based modeling, we are de facto basing our vision of the future and hence our decisions on inexplicit mental models, and we are driving blindfolded. So the assumptions here are that we are on 14.6% risk per infection trajectory, that virulence stays constant, so we don't have some more virulent variant or less virulent variant, that they are more or less the same, and that the reinfection rate is like it was in 2020 to 2023, so half reported infection per person per year. So with these assumptions, we can expect that by summer 2027, we will have 10 million people with long COVID symptoms at some time point, 6 million, that is 18% of Canadians with ongoing long COVID symptoms, and 1.3 million, that is 4%, with severe ongoing disabling long COVID symptoms. And so I zoom now on the ongoing long COVID. I made also a very optimistic projection based on recent data published on Quebec healthcare workers. This optimistic projection assumes that we would have 13% per first infection, and then that the risk would decrease with each infection. So 5% after second infection and 3% per infection with the third infection. And even in this optimistic scenario, the cumulative risk, the number of people with COVID will still substantially increase. So we can expect 3.7 million in 2027 having ongoing long COVID, which is 11%, and near 800,000 people with disabling long COVID. So, okay, again, virulence here is stable. If we have some variant, for example, BA3.2 taking hold, which is more immune evasive, then those numbers could be higher. And it's for adults. Unfortunately, I don't have good data for children, and I didn't make any predictions for children, but we can't forget about children. So what do we know? We know that 1, long COVID in children is common. 2, the number of kids with long COVID seemingly increases. So in UK, in England and Scotland, the number of kids with long COVID doubled within 1 year, from spring 23 to spring 24. And what was important, the steepness of the growth was steeper than for adults. And also this kind of disturbing recent study showing that the risk of long COVID, the incidence of long COVID, of long COVID in children after second infection was higher than after first infection, and also related diseases and symptoms, including cardiovascular and neurological, were substantially increased. And it was per infection that they had higher risk, not cumulative even. And fourth point is that children and adolescents are the most infected and probably most often reinfected age group among all ages groups. So we are infected less often than them. So given for above, we can expect that the steepness of the cumulative growth of risk of long COVID in children will be steeper than in adults. So so it doesn't need to happen because we know how COVID transmits, and so fortunately we perfectly know how long COVID transmits, and we know how to prevent it. We have all the tools to prevent COVID transmission. So COVID is airborne. Virus-containing aerosols can float like a smoke and accumulate in a room for hours. So by good ventilation, air filtration, and N95 respirators, we can ensure that the shared air we breathe is pathogen-free and prevent infection. And on top of this, if we have vaccines for everyone, especially children, we can reduce the transmission level on a population level even more. So here, I would really thank the organizers very, very much for making sure that we are safe here. So the CO2 levels here are really, it's below 600. So CO2 tells us how much rebreathed air is here. And if it's below 600, that means that the ventilation is actually excellent. But what's most important, we are all wearing N95s here, which means that probability that somebody gets infected here, that we transmit COVID, is very, 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 very low. So thank you very much. Thank you. I also would like to please visit a poster of my colleague, Mark Engreen, on building trust in science through self-correction. Okay, if you want to take a photo. And And I think this is more answer to the questions from yesterday, like how to advocate for people being aware of long COVID. I find this report by the Chief Science Advisor of Canada as an absolutely essential read and very helpful in advocating because it has so many good informations. Thank you very much.
Thank you. And now we'll go online to hear from David first.
Hi, testing. Can you hear me okay? Great. Hello, everybody. Part 3 of the panel. Thank you for having me, and my apologies that things changed on my end and with my air fare reservation, such that I am not able to be there with you in my hometown of St. John's. So you might notice my accent coming in and out. I think just by being vicariously there with you, my St. John's Townie accent is going to get more prominent. I have no significant disclosures to describe. So I'm a family doc and professor of family medicine at the Cummings School of Medicine here at the University of Calgary. I want to acknowledge those of you in the room who have helped us understand long COVID. So that this has been an often lonely, scary, maybe grim journey for many of you. And those here in our meeting, whether in person or online, and those who have contributed to and led efforts on long COVID awareness. I just want to thank you. I also want to acknowledge that I'm coming to you from where the Bow and the Elbow Rivers meet. This is a place where for millennia, people have gathered together to learn and share and grow from each other. So in this place called Mohkinstsis, Wichita and Gutitsis, this confluence of these two rivers, it has been where people have come together just like we are doing today. And that's extraordinary because what we're trying to do today is learn and share and grow from each other so that we can help bring transformation, how we can help people thrive and help bring some good sense to how we are managing and mitigating this incredible burden of disease, which has been wrought upon Canadians and people around the world. My positionality with respect to this topic is I care for patients with long COVID. I teach about long COVID. I have significant medical complexity, though I don't have long COVID myself, but I've had journeys that are, somewhat parallel those of somebody with significant long COVID. So by the end of this session, my objective was you will be able to describe strategies to help patients with COVID and their healthcare workers navigate the healthcare system. It really comes down to one key strategy, which we'll get to. A key part of this is understanding that the healthcare system is mostly made up of people. So I'm going to share with you my insights from giving a grand rounds in 2023. It was called SARS-CoV-2, COVID-19 induced chronic disease in primary care. It was primarily attended by 200 family medicine residents, but there were a whole bunch of other people online as well. And, doctors from a, wide variety of areas or whatever. Here were some of the comments and questions that came up in this session. And again, this was January 2023, long after long COVID, we knew it was real. Is long COVID even real? It's too confusing. I'm scared by it. So the big challenge is how do you navigate and work with scared, confused, and or ignorant healthcare professionals who are also tired, and approximately 40% of whom are likely depressed, as per recent data from the Canadian Medical Association, and work in a system in which novel long COVID markers and tests are not yet well known. Yikes. That's a big challenge. And the answer is with concreteness. Data. But it's not just any data. It's got to be, data that's familiar. That's the key to unlocking good engagement from potentially tired, confused docs and other healthcare providers who might be in denial about long COVID. Familiar data. So some examples. If you've got a patient with brain fog, let's use sequential MoCA test. So MoCA test is a Montreal cognitive assessment tool. It's scored out of 30. It's a bit tougher than the mini mental status exam. There are different versions available so that each time you do it, it's not like people are remembering that, oh, it's lion in the first time you did it, and now a month later, it's still lion. No, there's different images and different challenges that are of equivalent difficulty. It's very helpful as a baseline. So if you got somebody with brain fog, get this MoCA test as a baseline number. And then you can track progress over time and specifically response to potential treatments. So I had a patient once in whom we did try a novel treatment, and we were able to dramatically help her with her symptoms. And I was able to anchor and show it's not just her saying the words that she's so much better, but it's that we had proof on her evolving MoCA test. If somebody has fatigue or shortness of breath, the 1 minute sit to stand test is outstanding. You do sit to stand cycles without bouncing. I was going to do this in person. You measure it in 1 minute. And so people, when they stand and then sit and then stand and then sit, but you can't bounce and you can't use your hands. The key trick is that it's actually people's heart rate, oxygen saturation, and numbers of repetitions are often lower in long COVID. Now, the heart rate is a bit weird because you normally expect heart rate to go up with the more exertion. And if you've got somebody ill, heart rate would normally be higher, not lower. So that's weird. And that goes along though with long COVID. I've got the reference right there. The numbers of repetitions somebody's able to do makes sense that would be lower because somebody's going to be sicker on average if they have long COVID versus if they don't have long COVID. But this is the one that frankly is going to catch the attention of people. If you've got a patient and you can demonstrate that their oxygen saturation drops during an activity when it shouldn't, so oxygen saturation is the percentage of hemoglobin that has oxygen stuck onto it in the capillaries. It's measured by one of those finger clips. The doctors will pay attention to this, even if they don't believe long COVID exists, even if they're confused and uncertain about it. Hypoxemia, so a low oxygen saturation number, does catch attention. If you've got somebody with chest pain as part of their long COVID, ECGs are helpful, but the trick is that's just a snapshot in time. And they might not be having chest pain at the time they're getting a cardiogram, an ECG conducted. So instead, there's this device, and I have no conflicts of interest. The Cardia 6L has been actually advertised quite a lot on TV lately. It is FDA approved and approved by the FDA of olden times. It's only limb leads, though there is a potential hack where you can get chest leads. But it's why the device out of the package is limb leads only. And here's what's cool is that if you have a patient with chest pain as part of their long COVID, being able to get printouts of their cardiogram when they don't have chest pain and when they do have chest pain, you can compare them, and you're comparing apples to apples. And that's going to be very helpful as a clinician because there's certain cardiac conditions might be apparent. And one trick I recommend, though, is, again, if we're trying to catch the attention of healthcare providers who are tired, sick, 20% of whom have long COVID, as we've just heard from our two previous speakers, approximately, having them printed out on paper with clear, and I'm talking clear labels, like different color Sharpies at the top for no chest pain and chest pain, that is phenomenally better, easier to communicate with healthcare providers than if it's on your phone and you're sort of scrolling through. No, it just print it out. That's going to be a way to make things easy. And just in case you're curious, this is what we're looking for. So over here, this is a normal ECG morphology. What we're looking for is if somebody, say, happened to have a downsloping, that when they have chest pain, that might suggest they've got a particular type of angina. I won't get into details of that, though. So returning to the big challenge, how do you navigate and work with scared, confused, ignorant healthcare professionals who are also tired and maybe sick themselves, and approximately 40% of whom are probably or likely depressed, and work in a system in which novel long COVID tests aren't yet well known? And the answer is figure out how to capture the patient's health issues in familiar data forms. Number of infections, skin biopsies, because we're seeing all this new weird inflammatory skin disorders, way more in the last, say, 3 to 5 years than in my entire preceding 26 years of practice. Swollen joint diagrams. So use, capture somebody's symptoms in familiar data forms, and maybe even bring out a patient's symptoms in a way that can be objectively measured and concretely reported. Basically, you're bringing familiarity to the unknown and scary, and you're making it easier for healthcare professionals to engage with long COVID patients. So the key takeaway, use familiar ways to engage with people and health systems in the healthcare system. Doing so can help make this unfamiliar condition a bit easier to understand and handle, making it easier for you and your patients to access good care. One tiny PS, ask clinics in advance. So this is unrelated to the concrete thing. Another key tip to navigate the healthcare system, ask clinics in advance for people to wear masks during your encounters with them. Then they know up front. It's far easier. I've discovered this through my many interactions with the healthcare system. If you only remember to ask them on the day of, they might or should mask, but they're all confused and so on. Asking it in advance, it makes all the difference in the world. Thanks so much. May your healthcare journey as someone affected by long COVID be less lonely and more empowering, and may you soon thrive again in our shared world. Thanks.
And last but definitely not least, Matthew.
Okay, I'm going to start by introducing myself in Michif, which is the language of the Métis. Tanshi Kiewa, Matthew Oliver de Shinakashun, Selkirk G, Nitawakan, La Rivière Rouge Dus Chien, Amiskwaski Waska Hiken Nawikan. So hello, my name is Matthew Oliver. I'm grew up near the Red River, part of the Red River Métis family of Andersons, and on the matrilineal side, it's Soto, Truthwaite, Cooper, and Moore. I'm a guest here on Treaty 6 land. And grateful for the use of it. My thanks for the privilege to share a few words with you about Indigenous cosmologies. And shout out to all my Alberta cohort, David and Mark and Goja and everyone else for all the support over the last few years. I was really struggling to say something coherent, but I need to thank two Indigenous voices up front, Métis, Dr. Zoe Todd for her amazing writing, and a public health graduate student at UBC from the Algonquin Nation, Sierra Schollard, for her excellent article on racism as an Indigenous determinant of health. And just one caveat, I don't have any conflicts except I'm an engineer, so I don't know anything about medicine. I'm not trying to be pan-Indigenous. This is, there's hundreds of distinct Indigenous cultures in Canada alone, but this is a very high-level summary of what I've noted across nations. I'm going to start with a story from BC about mortality in First Nations individuals. And just want to say as well, this is not hating on BC. I think BC is one of the leaders in this space, particularly addressing Indigenous cosmologies in healthcare. But it's a good illustration of how easily cosmology is misapprehended, even by progressive institutions, and there's lots of other examples I could choose. So this is a 2024 report showing that First Nation life expectancy had decreased by 6.1 years, 2017 to 2021, described as a gut punch by Dr. Ben Smith, who's on the left in this image. Little change to the non-Indigenous life expectancy over the same base period, but 6 years for First Nations. I mean, it's outrageous and unacceptable. I don't know what else to say about it, largely due to the disproportionate impacts of SARS-2 on First Nations in BC, and of course, the ongoing impacts of colonial violence. And I expect the next report to show that the gap has widened further. Dr. Henry, the famous or infamous, depending on your perspective, Chief Medical Officer of Health in BC, made this statement that the report is two-eyed seeing, which she described as taking the best of the Western world and the best of Indigenous knowledge and ways of knowing and being and holding them up equally. This is where I want to start talking about Indigenous cosmologies, because this is a thin and rather inaccurate summary of two-eyed seeing. And these types of cosmology misapprehensions are at the root of failed reconciliation and the lack of progress in altering the impacts of health determinants on Indigenous in Canada. You can't address systemic issues in Western colonial structures until you understand how different our cosmology is from yours and how incompatible some concepts can be. Indigenous live under a huge power imbalance that puts that best of or equally gloss in a different light. Who is it who decides what is the best? Who is it who decides what is equal? Historically, that's one classic path by which settler colonialism asserts its dominant cosmology by assimilating Indigenous ways. And also invoking knowing and being as separate constructs is also quite foreign, as most Indigenous cosmologies have no concept of a separation between knowing and being, ontology and epistemology, if I want to be formal. We're almost always integrative. What I know changes my being, and my being determines what I know and what I may know. So a couple other cosmology illustrations to reinforce the point. This story from my home territory about the Southern Chiefs Organization seeking charter protections for the lake known as Winnipesaukee, Lake Winnipeg. And this is charter protections as a person. The lake is a person. The lake has agency. It's not allegory, metaphor, or a clever legal strategy. It's a literal truth. And we have an obligation to care for the lake, who in turn cares for us. Some photos from a slice of the boreal forest I'm privileged to be in relationship with, and a quote from Vine Deloria. What keeps Indigenous and non-Indigenous from communicating is we're speaking about two entirely different perceptions of reality. To hear what I'm saying clearly requires each of you to listen in a good way with an open heart and a deep humility that's willing to admit you don't understand other realities. Indigenous worldviews are also a means to teach healthcare providers how to work in a good way with everyone, not just with Indigenous clients. I love this photo of Raven. When I use this slide with Indigenous audiences, there's usually laughter when they read the text, that animal cognition is being rethought, and Western philosophers are opining that consciousness could be a fundamental feature of the universe. There are many, many stories and teachings about Raven in our communities. From when I was in grade school and learned only that primates could use tools, now you can find videos of Corvid all over YouTube reflecting something that Indigenous always knew. Raven is brilliant and has much to teach us. And our cosmologies have always seen consciousness, even in animals, as perhaps the fundamental feature of reality. So this is perhaps a sign of Western science finally catching up. So if two-eyed seeing isn't taking the best from both worlds, what is it? The term was originally applied by Mi'kmaq elder Albert Marshall out in your neck of the woods, where you're all listening to me, who co-authored several articles on integrative science explaining these teachings. And just a few steps from one of those articles reflects there's a deep and very different cosmology behind that two-eyed seeing, which is far more about learning how to exist in one cosmology while understanding enough of the other to interact without causing harm. And to highlight one line that demonstrates the immense difference, knowledge as a spirit, knowledge like water, rocks, trees, my warm slippers, my two cats, has agency. Again, it's not metaphor or allegory, but a literal reality. I won't spend much time on this busy slide. You can look at it afterwards. It's a comparison of aspects of two-eyed seeing in a Western STEM context and how different they are. I usually use this when I'm speaking to engineering students about Indigenous cosmologies. What I will highlight is that Indigenous cosmologies typically involve the three R's, relational, reciprocal, and responsible. So I am defined by my place in a web of human and more than human relations. All my relations in shorthand, you'll often hear people say. This web of relations, in turn, creates an obligation for reciprocity, where I use my gifts to care for my relations, who in turn care for me. And that fulfills my responsibility to live in a good way, what the Anishinaabe call Mino Bim Ad Iziwin. And just a nod to my colleague Mark Undren here, who gifted me this insight yesterday. Western science is designed to extract facts from reality by design and then to systematize and share those facts. So when Western science encounters Indigenous knowledge systems, which are by nature non-extractive and in relation, there will be harms. And Western science is oft unaware of the violence to both knowledge and people that's done by those extractive practices. So what are we to do for those of us who exist exclusively in a Western cosmology? Particularly if we wish to use our gifts to address those long-standing harms. There's a short but amazing talk by Chief Justice Robert Bauman called A Duty to Act. It's from a legal perspective, but it's very broadly applicable. And he makes this excellent observation. I'll read verbatim. Our assumptions about law and equity must be questioned. We must unlearn and, to be frank, defer. We must hold space for hard conversations and willing to be wrong. If there's anything that the last 200 years of Canadian Indigenous relations has taught us, it's that our jealous need for control is destructive. And it shouldn't be surprising that Indigenous medicine and Indigenous science and Indigenous engineering have wisdom and knowledge that's external to Western scientific systems. Even though the colonial enterprise has sought throughout history to minimize how ancient our cultures actually are. Just two examples, a recent article I saw talking about canoes they'd found in Wisconsin that dated back 4,500 years. It's roughly the Bronze Age in Europe. And there's been villages on the West Coast in Heiltsuk territory that date back 14,000 years, about 3 times the age of the pyramids. We're talking about ancient cultures here, ancient cultures that possess millennia of observational and trial data. I came across this outstanding master's thesis by Kiera Long that outlines a very insightful analysis of how Western systems misincorporate Indigenous knowledge. It highlights that striking these as separate domains ignores long colonial history of entanglement and how that leaves Indigenous domains oversimplified, romanticized, and unable to mount a credible critique of the dominant colonial cosmology. And some approaches limit Indigenous knowledge to safe domains, which reflects a very colonial approach. You leave the science to us, you stick with culture and spirituality, things we scientists aren't interested in and really don't accept as science anyway. I'd commend Kiera's entire thesis to you. It's quite wonderful. Finally, Dr. Zoe Todd emphasizes that two-eyed seeing is not so much attempting to smush together two different and sometimes unmixable cosmologies, but to exist in solidarity as people of different worlds who need to come together in humility to learn from each other. And the history of academic knowledge extraction and Indigenous culture is not a happy one. It's changing slowly. But even in preparing for today, I was dismayed to still see papers discussing Indigenous cosmology and culture with no Indigenous authors or credits given to the sources of knowledge. It's a challenge for all of us to set a different path by starting with relationship and knowledge exchange as a reciprocal activity that carries obligation through relationship. And that promise of relationship living together in a good way is what the Cree call Wakotowin, is what we understand treaty to mean. Two very different cosmologies living side by side, one not interfering with the other, but with an open and reciprocal exchange of who we are to the good of all, Wakotowin. And I thought I'd finish on a happy note with a picture of one of our four-legged more than human relatives. This is Reki. Reki is a human remains detection dog trained by a classmate and former colleague of mine, Kim Cooper, out of Ottawa. Kim's last few years have involved participating in many, many searches for unmarked graves at former residential school sites. I love the image because Reki's a super pup, but this is what a reconciliation really looks like in motion, a coming together in community to work to be good relations and walking together in a good way. Marcy, thank you, hi, for listening.
Thank you so much. Which one's working? This one? Okay. Thank you so much. Would you join me in thanking our four speakers? I told you, I promised you a treat. I think that was time for questions.
Hello, thank you for an excellent presentation with regards to Indigenous peoples. Just a question really. I know that the pandemic was catastrophic really for Indigenous peoples, and your figures on the reduction in life expectancy has illustrated that. But there seems to be a dearth of research going on or acknowledgement of the impact of SARS-CoV-2 on the Indigenous community. I worked briefly as a family physician in an Indigenous community in the first third of the pandemic, and I saw people with long COVID, and there just doesn't seem to be any service. There's no acknowledgement. Even at this conference, there hasn't been any. We've not heard about any research on the impact of long COVID on Indigenous peoples of Canada, and I just wondered about your thoughts about that, or whether you've heard of anything going on or anything being done by the First Nations Health Authority with regards to long COVID resource, long COVID research, long COVID acknowledgement in the Indigenous communities?
Thanks. Super question. No, I'm not. I'd been asked last year at some point that didn't come off, but to do a presentation on air cleaning mitigations for a friendship center in Ontario. And as I was digging through that, there is like nothing, even around the simple topics of simple topics around how you might bring cleaner air into Indigenous communities, which are struggling with even more basic infrastructure needs, like not having connections, reliable connections to sewer or clean water. It's almost an overcrowding. It's almost a bridge too far to start now talk about, well, now we need to put HEPA filters in all their houses when they don't even have reliable basic infrastructure. I've not seen anything out of the First Nations Health Authority. If somebody was doing it specifically, it would be them, but I can't speak to it beyond that. But I mean, as you know, it reflects it's not like this is a surprise with COVID. This is an issue which exists for Indigenous communities and has for a long time in Canada, that there is an under degree of study of specifically what's going on with them. I do note there's a poster session. You should go over and look at the poster on interventions with Indigenous communities, culturally safe interventions. That's quite good.
Okay, and I just wondered if you had any idea of how we can reverse this situation. I know the Indigenous community has been overwhelmed with the fentanyl crisis, and I think that's dominated the healthcare situation. But I know that there are at least twice the numbers of SARS-CoV-2 infections in the Indigenous community. So the long COVID numbers must be extremely high, and people must be suffering. And I know their access to primary care is very much reduced than in the general population. In the general population in Canada, 1 in 5 have no family physician. So any ideas that you might have to sort of reverse the situation would be gladly heard.
Wow. So for my next 2 hours of presentation, I'll talk about how to decolonize Canada, because that's actually the question you're asking. I mean, there's a default dismissal of Indigenous issues, Indigenous bodies in Canada still. I mean, during the active emergency phase of the pandemic, when the Stoney Nation here in Alberta presumed to put up signs that said, "You cannot enter our reserve lands," there was an outcry from certain segments of the population that said, how dare they put up signs saying we can't drive wherever we want, even though it's actual federal reserve land. You don't have a right of access to it. So when Indigenous communities try to assert that and try to bring increased health about, there's often a strong pushback. And you don't have to go far to find just the horrific stories. For example, during SARS-1, was it, or MERS, the response when a Northern Ontario reserve asked for assistance was they got a shipment of body bags sent to them. And this is a present reality in Canada. It's not an ancient history. Peter Bryce's comments about health and the residential schools, a lot of that stuff is almost directly applicable to today. I don't have any easy solutions. One of the things that's changing is there are more Indigenous physicians now, which is awesome. Dr. Ben Smith, in my lead story, who's the Deputy Chief Medical Officer of Health in BC, brings that perspective in, and they're starting to transform things. But as Murray Sinclair said about reconciliation, like, this is not a generational, or this is not a lifetime issue. This is a multi-generational issue to resolve. And all of the things that led to Indigenous being placed on reserves are also the things that prevent them from having access even to the sort of problematic healthcare that we have access to if we live in urban areas. Yeah, so I don't have any easy solutions except to say to everyone, the marginalization that long COVID's the long COVID community experiences from healthcare is an analog to what the Indigenous communities have always experienced, and it's almost an intractable problem.
Gary, if I can add to that, think of what I just talked about and what Matt talked about. And basically what I'm talking about is there's a deeply entrenched colonial mindset that refuses to listen to patients who are ill. And my solution is go all in and hack the colonial entrenchment. Go to those concrete measures and tools and structures, which, okay, it gets you your patient care now. But then Matt is telling us about Etuap monk and what it means. And on his chart, it's really clear that what I'm talking, like, this is, it's these things can't be equivalent. No, what we need is to get rid of the hubris in our healthcare structures and systems and training, and be open to the fact that, and not just open, but assume that the vast majority of patients are not lying, and work with them. And instead, what we're having to do is use sneaky hacks and so on, because people are deferring when they're tired and sick and confused. They're deferring to colonial structures so that they don't have to deal with their confusion or uncertainty about this new disease, which is rotting, such danger and illness on people. And exactly, thank you, Matt, for identifying this is just a glimpse into what the oppression of genocide, of Indigenous genocidal activities has been over like centuries.
Any questions online?
Yes, there are. Just another small question. The question, I've combined a few here, and I think this could be addressed to any one of you. Feel free to jump in. But to what extent is the rate at which the population developing long COVID, to what extent is it a threat to the stability or future of our economy? Are we at a tipping point? Are we headed to a tipping point or a mass disabling event? And are there road signs for people to understand what is happening?
I mean, so this is David again. Sorry, get my video back. I was, Matt, why don't you talk about the submission we made to the government, the federal government?
That was directed at me, David. You said Matt?
Yes, sorry.
Yeah. Thanks for your comments, by the way. You're bang on. Yeah, I mean, I think we're past the tipping point, actually. I'm a member of the disabled community as well, and one of the reasons I've been an advocate for clean air and COVID interventions is because I don't want people unnecessarily have to join that community. But I was just looking again at accident rate numbers yesterday evening, and we're starting to see the hallmarks of cognitive injuries that are coming out as a result of multiple COVID infections. And literally every day now, it's another ton of fine research papers from some of the people at the conference. And thank you very much for your work. That's reaffirming the suspicions we had back in 2020, 2021 about what was going to potentially fall out of this. So we've attempted, written some articles, made some submissions, calling for a national COVID inquiry. If the UK inquiry has done nothing else, it's at least illuminating the deceptions and the twists that have happened by bringing it out into public view. And maybe that's a salutary outcome just by itself. But we really need some systematic and organized response to address the fact that we have, like as David just pointed out, every day when I drive on the freeway now in Edmonton, there are multiple instances of, I don't even download my dash cam anymore because there's too many of them to download. It happens so frequently, of people that are doing just horrifically dangerous things that I never saw routinely before. So lots of anecdotal evidence supporting that. Just to call out one of the elephants in the room about that, the problem is that a lot of the people that are in leadership positions have a vested interest in not actually making those inquiries and bringing that information out, because they were the ones who were saying in 2021 things like there's no high quality evidence that respirators work to prevent viral transmission. And I mean, there were people swearing documents in court cases right in Ontario that said SARS-CoV-2 is not transmitted by aerosols, even when there was evidence at the time that it was exactly being transmitted by aerosols. So I'm not a conspiracy theorist, but it would be naive not to acknowledge that there are a lot of people who have interest in not actually having stuff brought out, which is why we're in basically the same situation that Justice Archie Campbell and Mario Posami was after SARS-1 in Toronto in the SARS-1 Commission inquiry. Trying now to call for documentation of all the problems we had so that maybe the next time around we won't see it. And both Nicole and Gosia may have comments on that because from the data side, they've clearly shown that I agree with what David just dropped me in chat, that we're actually past that tipping point.
Thank you very much. I don't think there's time for any more questions. Maybe time for a comment from our panel yet?
Yes, so I totally agree that we are past the tipping point. If there is a tipping point or just everything is growing, like the disaster is growing, and I think it would be great to have some economists follow up on the projections to put in numbers how much worse it will be, what will be our reality in 2027, in 2028. And I think also the problem with long COVID is that it affects very much the people in the prime working age, and especially people in caregiving industries like teachers, education workers, healthcare workers. So we will have less people we'll have more people needing care and less people able to provide care. So from both sides, we are having a impact.
Last word? No. Thank you very much. I think you can agree that was an amazing wrap up of the pillars.